Hey, good day and good evening, everyone.
Good
It's
evening.
Tuesday, so it's the day of IVF webinars. I hope you are doing fine, and I'm glad that you are here with us again today. And please let me know if you can hear me properly. I would appreciate this information from you, and the feedback, it will help a lot. I'm Sophie, and I'm your host today. As every Tuesday, we meet here and we are here with you and actually for you. And we are doing IVF webinars. We have done over 60 IVF webinars so far, and all of it you can find on our website, eggdonationfriend.com/IVF-webinars. IVF webinars are brought to you with the help of our partners, and our partners are Eiselspende, fertility clinics abroad, and Donor Conception Network. And this is also high time to introduce our guests. And today we are here with the specialist from Salve Medica Clinic, and let me welcome Małgorzata Wójt, head of the embryological laboratory at Salve Medica, and Agata Olborska, junior embryologist. And this strong team will show us what do your embryos really look like and explain to us embryo grading and quality assessment. The presentation will take around 20-25 minutes, and after which we will, of course, start with your questions, and we will do a Q&A session. So if you have any questions, you can type those questions in the chat section, even during the presentation, and we will ask those questions after the presentation. This webinar is recorded. As always, you will find the webinar tomorrow on our website. It will be available without any limitations, so you can rewatch it, share it, and use it freely. That's all from me for now. If we are ready, we can start. Małgorzata, Agata,
Yes,
are you ready?
Yes, we are ready.
Welcome, fingers crossed, and let's do this.
Good evening. My name is Małgorzata. It is my colleagues Agata. We are embryologists. I working in Lodz. My colleagues working in Warsaw. So we started. At the beginning, short course of embryology. This photo shows how development progresses from the fertilized egg to the blastocyst. On the first picture, we see correctly fertilized egg. Next is two blastomers embryo. It's embryo about 25 to 40 hours after fertilization. Next is today's embryo is excellent. Today's embryo with 4 blastomers. Next is 8 blastomers embryo. It's embryo at 3 days. On the fourth picture is molar stage embryo, and the last is blastocyst. It's 5, sometimes 6 days embryo. On the next slide, we will show more details related to the oocyte quality and development and the evaluation. Okay. From oocytes to blastocyst. At the beginning, there was an egg. In the medical nomenclature, oocytes. Oocyte is the most important factor in embryonic development. How we see good oocyte not always is equal with good blastocyst, because there are different factors. For example, quality of semen. We haven't forgot about also genetic competition of this oocyte. But in general, the better oocytes, the greater the chance for a correct top quality blastocyst. This blastocyst is for AA is a very good blastocyst, a top quality blastocyst. Okay. This is a completely different situation because it is abnormal oocyte. Abnormal oocyte almost always is poor embryo, poor development to the blastocyst. There are no definitive studies that shows about embryo development based on oocytes quality, but often there are simple relationships connected with quality of oocytes. Different human oocyte morphological abnormalities. On these pictures, we see different oocyte morphological abnormalities. For example, in the A is diffuse cytoplasmic granularity, very often connected with lower cleavage rate and more fragmented embryo. The next is similar situation because also is granular cytoplasmic, also reduce implantation rate and embryo quality. See picture, smooth endoplasmatic reticulum clusters is less likely to develop into blastocyst and implant. D is vacuoles, sometimes is one but bigger vacuola, significantly lower fertilization rate, sometimes is also connection with embryonic arrest. Next picture, abnormal zona pellucida shape is associated with diminished pregnancy and also implantation rates in IVF. Implant and large perivitellin space with fragments very often is correlated with low fertilization rate. First day after IVF or ICSI, we observe fertilization. Correctly fertilized embryo, oocyte have two polar body and two pronuclei. For embryologists, is also very important nucleoli. It is small structure inside the nucleoli. Their quantity and their distribution inside nucleoli has impact on development embryo. Assessment in the first day is the crucial because often the next hours and days we will not be able to assess the fertilization abnormalities. Abnormal fertilization gives genetic disturbance. On the second and third picture, we see the most common anomalies. Unfortunately, such embryos can develop to the normal, sometimes top quality blastocyst, but they won't give birth to a healthy baby. It's very, very important. To support the work of embryologists, I use time-lapse system. Time-lapse system gives us more information, morphokinetics, as seen with time-lapse, can enhance the power of embryo selection because it allows for morphological to be assessed more accurately. Time-lapse embryo monitoring allows continuous, non-invasive embryo observation without the need to remove the embryo from the optimal culturing conditions. The extra information of the cleavage pattern, morphological change, and embryo development dynamics could help us identify embryos with a higher implantation potential. Example device, incubator with built-in camera with software to collect a lot of data during culturing embryo.
Okay, so my colleague told you about assessment at day 1 after fertilization, but later on we have a cleavage stage embryo. and quality assessment of cleavage stage embryo is really important to select the top quality embryo for transfer on day 3. And the assessment is based mainly on 2 criteria. First of all, on cell number, and secondly, on cell morphology. And what is important to say, there are many publications available that approach the subject in different way. And according to Jerris et al., the top quality embryo includes 4 or 5 blastomers at day 2, and at least 7 or 8 blastomers at day 3 after fertilization. What is important to note, the blastomers should be at the same size. At the blastomers, there should not be any multinucleation, and the fragmentation presence in embryo should be less than 20%. On the other hand, Sakas et al. Publication reports that 2 cell stage at approximately 25 hours post-insemination or microinjection is a critical criterion to select the best embryo. And according to them, they think that this is the most powerful parameters to predict to develop the morphology, to good quality morphology at day 5. And what is important, the patient should remember that different IVF laboratories use different assessment standards, especially at this cleavage stage embryo. When we assessed a blastocyst stage, we usually use the most common scoring assessment for blastocysts, which has been developed by Gardner and Schoolcraft. And this scoring system is based on 2 main criteria. First of all, the expansion state of the blastocysts, and secondly, the consistency of the inner cell mass and the trophoectoderm cells. As you can see in the picture, the green arrows show you the inner cell mass, and this is the part of the embryo which will form a fetus. The blue one shows trophoectoderm cells, and this part will form a placenta. And the red arrow show a blastocyst cavity. So when we are talking about blastocyst stage embryo assessment, the grading scale has 3 degrees, from A, which is the best, to C, which is the worst on this scale. And when we are talking about inner cell mass, and when we assessed as A, there are many cells which are tightly packed. B, there are several cells which are loosely grouped, and C, there are very few cells. And the trophoectoderm, A, there are many cells forming cohesive layer. B, there are few cells forming loose layer, and C, which is the worst, there are only few large cells. We can distinguish 4 main expansion states of the blastocysts. 1, it's called the early blastocyst, and the blastocyst cavity is less than half volume of embryo. 2, it's when the blastocyst cavity is more than half volume of embryo. 3, it's called full blastocyst. So the blastocyst cavity completely fills the embryo. 4, expanded blastocyst. So the cavity of the embryo is larger than before in embryo, and the zona is thinner. And sometimes in the IVF lab, we can also observe 2 more grades of blastocysts. So 5, when we have a hatching blastocyst, is when the zona is breached and the embryo hatch out. And 6 is really, really rare situation, hatched blastocyst, so the blastocyst has completely escaped from the zona pellucida. Now you can see a sequential embryo assessment, and at the first picture, it's approximately 18-19 hours after ICSI, so it's day 1, and the embryologist assess the presence and quality of pronuclei. And when we look at the embryo 25 or 26 hours after ICSI, the embryo should be cleaved into 2 cells. It's a good factor. 42 or 44 hours after ICSI, so day 2, the number of blastomers should be at least 4. The blastomers should be at the same size. 68 hours after ICSI, so it's day 3. The number of blastomers should be at least 8 or more, of course. 92 hours after ICSI, it's day 4, and the embryo should be at morula stage. So the embryo should compact all blastomers and make one.
One.
Yes.
Sometimes it's very similar as all sides.
Yeah, exactly. And at day 5, the embryo should be at the blastocyst stage, and as we can see, this is a really, really good blastocyst, assessed as 4A. And now we can see all these steps on the movie. So you can see the extraction of the second polar body. Now 2 pronuclei appears. And this is approximately how I can see before, after 18-19 hours after insemination. The embryo cleaved to 2 cell, to 4 cell. And this 4 blastomers cleaved again into 8 cell embryo. The embryo is starting to compaction, as you can see. It is really important stage because there is a and now we can see an early blastocyst. Blastocyst is a full blastocyst, and now we can see really expanded blastocyst. Yeah, this blastocyst was transferred and successfully implanted. So embryo assessment provided by an embryologist is a key to choose the best embryo for transfer. And an example below confirms the thesis, because we will see 3 different embryos from the same patient and the different ways of development of this embryo. So embryo number 1 and embryo number 3 has 2 pronuclei. Unfortunately, embryo number 2 has 3 pronuclei. This means that this embryo is triploid, and unfortunately, aneuploidies are commonly observed in early human embryo. In the second line, as you can see, all embryos cleaved into 2 blastomers, and all embryo cleaved into 4 blastomers. And on the second line, you can see that still all embryo cleaved into 8-cell embryo. I know that in the embryo number 2, it's not so good visible that there is 8-cell, but yeah. And we can see a different way of development of this embryo, because embryo number 1 and embryo number 2 is compacted, but embryo number 3 no. And this means that the embryo is at cleavage arrest, and it has been suggested that cleavage arrest may occur as a consequence of failure of gene activation. And the last line show us day 5, and the embryo number 1 and number 2 are at blastocyst stage, but the embryo number 3 are still at cleavage stage embryo. And now we can observe the movies of this embryo, which picture we saw. So embryo number 1 and embryo number 3 have 2 pronuclei. The second embryo has 3 pronuclei. They pretty good divide into 2 cells, and all divided into 4-cell embryo. Please note that there's no fragmentation in these embryos. Every embryo again cleaved, and we can see 8-cell embryo. The embryo number 2 and number 1 start to compact. The embryo number 3 are at cleavage arrest. Yeah, and we can see early blastocysts on the first and the second movie, and they are expanded. And the last thing I want to say that this is also important not to cross out the change for a blastocyst stage, despite the less than perfect development of the embryo, as we can see on the movie. So yeah, the first assess is okay because we have 2 pronuclei, and we saw the extrusion of the second polar body. But the embryo divide into 3-cell, unfortunately, and we can see there is a presence of of fragmentation on this embryo. So the blastomers aren't at the same size, and at the embryo is a fragmentation. And what is important to note on this embryo, that is again cleaved, but the blastocyst stage in this embryo is achieved from compaction, not from all blastomers. So the compaction is here, and here are some blastomers left.
Now we have a very important question: when to transfer, cleavage stage or blastocyst stage. The efficiency of blastocyst transfer is not inferior to that of embryo transfer at the cleavage stage, but performing blastocyst transfer may have benefits because morphological assessment on day 3 has limited predictive value for subsequent embryonic development. The maintenance of embryo culture until day 5 may be a more sensible approach for the correct identification of the best quality embryos with the highest probability of success for implantation. According Cochrane library included 27 randomized clinical trials under 4,000 couples or women that clinical pregnancy rate was higher in the blastocyst transfer group following the fresh transfer. This suggests that if 36% of women achieve clinical pregnancy after fresh cleavage stage transfer, between 35 and 46% would do so after fresh blastocyst stage transfer. We can see similar result in everyday clinical practice. Sometimes we hear that cumulative pregnancy rate. Cumulative, it means that we have fresh and frozen transfer. That cumulative pregnancy rate is very similar, regardless of the data of date of transfer. It's true, but the blastocyst transfer gives a faster pregnancy because there are fewer transfer. Thank you for your attention.
And thank you a lot for your presentation and videos which we have. We will now take the time for the questions, and please type your questions in the chat section if you have any. I will ask those questions, your questions, one by one. And we will start with the first question which we have. Just a second. And this question will be this one. Is there an expected percentage of day 3 that will make it to day 5?
I don't understand. Expected percent of success, or I don't understand.
Yeah, probably of embryos, right?
Okay. General is good laboratory result if half of 3 days embryo develop to the blastocyst stage. It's normal development if half of day 3 embryo.
And thank you for the answer to this question. We will now take a look at the next one. What if there are 10 cells and the doctor decides to implant on day 3?
I think it's a good quality of embryo if there are 10 cells with no fragmentation, with no multinucleation at the embryo. It's really good because at day 3 we should have at least 8 cells. So 10 cells embryo is okay.
But if, of course, it depends how many embryos has this patient, because if it's only one embryo, transfer on day 3 is very good. But when we have more embryos, in my opinion, better will be wait and develop to the blastocyst stage.
And huge thank you for explaining this to us as well. We will jump to the next question, and this question will be this one. I have embryos graded 5BB. What exactly that mean, and what could be success rate with that gradation?
It is hatching blastocyst. BB is maybe not top quality blastocyst, but if its embryo is in day 5, it's quite good embryo. But success rate not only depend of blastocyst quality, it depend of endometrium, of age of patient. It's not only depend of quality embryo.
And thank you for this answer as well. We have another question which is connected to the grading itself, so we will take it. I had a 6 BB transfer today, and the doctor said it is a very good quality embryo. Is that correct?
Maybe not very good, but good quality embryo.
It's still good.
It's good embryo.
Yeah, but it's hatched from the zona pellucida. Yeah, because it is 6.
And thank you for this answer as well. And the question, of course. We will take a look at the next one, grading again. What is the maximum grade for an embryo?
6. It is completely hatched blastocyst.
Yeah, and when we can assess the inner cell mass and the trophoectoderm, AA is the maximal for assess.
AA is the top quality.
For this explanation, we will now take a look at the next question, and this question will be this one. The clinic where I had 3 transfers also has blastocysts on the list, embryo donation, which have expansion 6, for example 6 BB. So it is the highest expansion. Is it okay to transfer such an embryo?
Generally, I don't like 6 expansion because it's a very sensitive embryo, because it's this embryo don't have zona pellucida. Zona pellucida is safer. So sometimes, of course, it's not depend of laboratory. Sometimes blastocyst hatch
so fast.
Yeah. But generally, we try to
avoid this situation.
Avoid this situation. Yes.
And thank you for this explanation and answer to this question. Next question we will look closer will be this one. How about frozen embryos? Is another assessment done just before the transfer?
No, it's the same. It's the same. Now, I think that maybe not, but many clinics using vitrification to the frozen embryo. Vitrification is very. It's very
safe
way. It's a very safe and don't change the quality of embryo.
But you should remember that, for example, if we tow embryo, for example, 5 or 6 hours before the transfer, the blastocyst could grow and expand. So the assessed could change, because when we, for example, vitrificate blastocyst and stage 2AA and we leave it at the incubator for 6 hours, for example, when we do the transfer, it could be at 3AA stage, and that's normal.
Thank you for your professional opinion on this question as well. Next one, which we have on the list, is this one. If you had a one low quality blast and one higher quality, would you transfer both?
No, because every embryo different different working with endometrium. So we transfer one embryo. Of course, when we have 2 similar embryos, it's also possible transfer both, but not this situation. One low and one higher is not a good solution.
And thank you a lot for this answer to this question. The next one is this one. Is a completely hatched embryo not the best for immediate implantation?
It's a very difficult question because, of course, it's completely ready to implantation, but it's not safe. It's not very safety situation. We talked about a few minutes ago about this situation.
Yeah, so you should remember that when embryo is hatched, totally hatched, it's really sensitive, and the transfer should also be really
Careful.
provided carefully.
Thank you for this explanation to this important matter. Okay, we will now take the next question. And this question will be, any tips after embryo transfer on what you can do to help implantation?
First, many times, very often in our clinic, you use embryo glue, a special media with very rich hyaluronian. So it's embryo glue is the first. Second will be assisted hatching. In our clinic, we have laser, so we perform assisted hatching by laser.
Thank you for the question and your answer, of course. We will now take quite interesting question, I think. Dermatology and radiology already enjoy support by artificial intelligence. What is your opinion about embryologists supported by AI already available?
It's a difficult question because artificial intelligence in embryology lab is.
You are not convinced by that.
Yes. Sometimes will be help. Still in embryology lab decided human.
Okay, and thank you for this question and the answer, of course, to this one. The next one, which we have already asked, is this one. Can you freeze embryoblast at any quality, or does it have to be high? Also, what is the rate of thawing embryos?
So in our clinic, we freeze embryo at stage blastocyst and any quality, because we have some situation that the couple has only one blastocyst assessed as 2 cc, so it's really poor blastocyst, and they decided to transfer this blastocyst, and we make assisted hatching, and successfully this blastocyst was implanted, despite the fact the quality was really poor. So yeah, we freeze embryo at all quality, not only this which are assessed the best.
But the rate of thawing embryo is almost 100 because during vitrification embryo is safer. So thawing is almost 1,000. 100, sorry.
And thank you for your explanation to this question as well. The next question we will take a closer look at will be I read that in mosaic aneuploidy, the embryo can sometimes segregate and destroy the abnormal cells and end up developing into a healthy baby. In the earlier video with 3 embryos where the second one had some cells at the perimeter that were not part of compaction, could that be what was happening?
Aneuploidy is a different mosaicism is a different situation than aneuploidy. Aneuploidy is a situation, for example, when we have 3 sets of chromosomes. But mosaicism aneuploidy, it's, for example, when we have not whole sets, more and less, but we have only one or more chromosomes. It's a different situation when we're developing, when we earlier video.
But the fact that some cells were not part of compaction, it doesn't mean that this embryo is a mosaic aneuploidy. It's not equal.
Thank you for you explaining us this complicated matter, I think. I have also a follow-up comment on this question, so I will give this as well. Okay, I understand. So then for some trisomy or monosomy chromosomes, it can segregate bed cells?
It's trisomy or monosomy is problem. Many trisomy is disease, for example, with Down syndrome. Monosomy generally is lethal, but sometimes we have mosaicism embryo, and quality of genetic quality of this blastocyst, it depends how many cells is segregated, how many mosaicism is in this embryo. If it's a low level of mosaicism, sometimes this embryo is ready to transfer. But not whole. When we have embryo with whole trisomy or monosomy, this embryo isn't transferred.
And thank you for adding this information to the previous question and follow-up comment as well. We will now take a look on the question about grading. Again, I have two straws of embryos in the freezer, one with 3AA and 3C, the other straw with 3BB and 3BA. Which straw should I use first?
First, 3A. Of course, it depends also in which days will be which will days have frozen. If the whole straws will be in day 5, first we use 3A, next 3BA, third 3BB, and the last 3C. Sorry, because now I see that is 2 straws only, and one. First, we use this straw with 3BB and 3BA because it's good quality embryo, maybe not top. But good quality embryo, and 3C embryo is poor embryo. So first we use 3BB and 3BA.
Okay, thank you for this answer and for the question, of course, as well. And the next question which appeared is this one. And what is your opinion of PGTA testing damaging the embryo? I'm hoping to be able to use an ICS instead, non-invasive chromosome testing, to better test for mosaicism without damage to the embryo.
I think when PGTA testing is performing by embryologist which has a lot of experience. It's quite safe, and if you have a blastocyst and the blastocyst is built of approximately 120 cells, and you take only a few to the testing, it's quite safe to the embryo.
Yes, and thank you for these answers to the question. We have the next question coming up. Some embryos are still frozen by the old slow freezing method. Which chances have such embryos to survive after thawing?
Generally, slow freezing method is in the blastocyst stage, because in earlier stages is different. But in blastocyst, survive after thawing is about 90%. in the cleavage embryo 85 to 90.
And thank you again for the answer. The next question is this one. Can you transfer a slow-growing embryo at day 7?
No, in fresh transfer, because we transfer only in day 5. But in my career, I frozen only 3 times 7 days embryo, and 2 of these transfers was successful. For me, it's completely difficult, maybe not difficult, but it's completely abnormal situation, but sometimes it's okay.
I read some paper that the scientists compare the pregnancy rate after transfer frozen embryo and blastocyst stage at day 5 or day 6. This was the first group, and the second group was the embryo which achieved the blastocyst stage at day 7 or at the day 8. And the pregnancy rate at the first group was approximately 38%. On the second group, the pregnancy rate was only about 5 to 6%. So it's a huge difference in successfully. So yeah, I think we avoid.
We avoid. Generally, we frozen in 5 and 6, but transfer only day 5.
Thank you for giving us your professional opinion on this matter as well. We will take the next question, which could be probably the last one. For now, we don't have any more questions, but if anybody waits till the end, it will be really the high time to do that. We will be slowly finishing. So if any questions left on your mind, please type those questions in the chat section. In the meantime, we will take a very interesting question, I think, and practical. What could I ask the clinic to know the embryologist is experienced and skilled enough to do a good biopsy for PGTA testing without damaging the embryo? How many cells can safely be taken? I know some labs do 2, some do 5.
I think during biopsy, embryo biopsy, the best results when we have 5 to 8 cells from blastocyst, not from day 3 or not from day 3 embryo, because from day 3 embryo only 1 blastomer. But from the blastocyst, we biopsy 5 to 8. Because it's
enough.
It's enough to good quality testing.
And thank you for answering this question as well. In the meantime, as somebody is typing, so probably it will be the next question, I will show you some shout outs. Thank you for your answers so far. And yes, the question pops up. And this will be this one. Do you think that labs not using time-lapse to observe embryo development are at disadvantage in judging embryo quality?
I don't think so. The time lapse, it's
useful devices, but it's not have influence on the embryo quality. On time lapse system is for embryologists is the very important tool, but it haven't any influence of the embryo quality.
And thank you for the question to this answer as well. Somebody is again typing. So we will, yes, and it will be the final question as we are running out of time. So I will publish that in the second. Does it not help to observe pronuclear count at compaction? time-lapse, I mean?
Time-lapse, of course, help, but if a laboratory don't have a time-lapse system, is organize a working laboratory. That means, for example, we have maybe not we, because we have time-lapse systems, but when we don't have a time-lapse system, we evaluate on the special times. For example, after IVF or X is 16 or 18, 16 to 18 hours after fertilization. The first cleavage is 25 to 26 hours. So it's very useful tools, time lapse, but it's not change of embryo quality.
If the IVF lab don't have a time-lapse incubator, they organize their work the best to assess. So somebody should be at the lab after 18 or 19 hours after microinjection, because this assessment must be performed. So yeah.
And thank you for this question and all your questions today, and for all the answers that you gave us. Again, we will have some shout outs. Thank you.
Thank you so much.
Thank you so much.
Thank you.
It was very informative, the presentation and the answers to the questions which we heard from you. And of course, we have more thanks. And the closing one. Dziękuję.
Dziękujemy.
Thank you. Yes, thank you, everybody. Thank you for this evening, and thank you for being with us, especially for your time. And it's both to everybody who was with us this evening, and for you, Małgorzata and Agata. Thank you for all the knowledge you gave us. If you have anything to add, please do that. I hope you liked it.
Yeah. Sorry.
Yes, I'm glad that you liked it just a little. And yes, I hope that we will meet here someday. Of course, this webinar will be available on our website tomorrow, but you can stay up to date with all the content we have by subscribing our YouTube channel or by following us on Facebook or Instagram. And of course, we are here every week. So if you join us next time, same place and same time next week, it will be a huge pleasure to have you here. Thank you one more time. We will be finishing for today. And yes, see you next time here. Bye.
See you. Bye. Thank you.
Bye.